Alright guys, let's get busy talking about schizophrenia. This is a really big topic on test day, and test writers really like you to pay attention to the symptoms and the diagnostic criteria because there are a lot of variations on the schizophrenia spectrum. So let's start from the ground up and start by talking about some of our symptoms. So we'll start off by talking about positive symptoms, which are going to be characterized by things like delusions, hallucinations, bizarre and inappropriate language, as well as strange behavior. These are a lot of the symptoms we talked about in our psychosis video. Now, we are also going to have negative symptoms associated with schizophrenia, and these symptoms are flat affect, psychomotor retardation, anhedonia, and poverty of content. What exactly is a flat affect? So a flat affect occurs when you talk to someone and they respond to you in a very monotone, kind of depressed way. So if I was talking to you guys like this, I would have a very flat affect. That is an example of a flat affect. That's not how I usually speak to you guys, but that might be how someone with depressive symptoms of schizophrenia is presenting. Now, what about psychomotor retardation? Psychomotor retardation happens when people are having a lot of difficulty with simple motor skills, and this can be another depressive symptom of schizophrenia. What about anhedonia? We talked about this in our video on major depressive disorder, and anhedonia is going to be when people stop feeling joy in things that used to bring them joy. And lastly, poverty of content. And poverty of content is just going to be someone who's having a conversation with you, but really the content of the conversation is not very meaningful. So it's going to be very simple things like you would expect when you're having a conversation with a kindergartner. Nothing advanced, nothing adult level. Additionally, we're going to see some changes in analytical ability. So analytical symptoms are going to include things like decreased memory, decreased cognition, decreased synthesis, and decreased faculty of logic. So essentially, people with schizophrenia, their brain power goes way down and they're going to struggle with higher order tasks that you and I would be able to do quite easily. Alright, so let's start talking about some of the diagnostic criteria because they are so important. So we're going to have greater than 2 or more of the following, with 1 or more from criteria numbers 1 through 3. So let's talk about criteria 1 through 3 first. These are going to be our classically active symptoms. So things like delusions, hallucinations, disorganized speech. You need at least one of those to qualify for a diagnosis of schizophrenia. In addition to that one active symptom, your sum of 2 or more can come from the last 2 bullets here. So negative symptoms, so any of the things that we highlighted above up in blue. And then disorganized or catatonic behavior, which I'm going to highlight here in purple because it's kind of a mixture of an active symptom and a depressed symptom. Because disorganized thought we kind of think of as like an active red symptom, and catatonic behavior, which is more of like that flat affect type behavior, is more of a depressive symptom. So I'm highlighting that one in purple. So that purple and that blue criteria can be part of your 2 or more, but one of those 2 or more has to be from our red active symptoms. Now, the last and probably most important thing here is that these symptoms have to be for greater than or equal to 6 months with greater than or equal to 1 month of active symptoms. And this is really important because you do not want to give a diagnosis of schizophrenia to someone. So we have this large 6-month period for them to hopefully snap out of their symptom profile. But if they make it to that 6-month mark, then they are officially given a diagnosis of schizophrenia. So let's talk about some of the other differentials on the schizophrenia spectrum. So we'll start off by talking about schizophreniform, which I think is one of the easier ones because this is essentially the same as schizophrenia, except it just does not make it to that 6-month mark. So these patients are going to have 2 or more symptoms for 1 to 6 months, whereas our patients with schizophrenia, we're going to have 2 or more symptoms, including an active symptom, for at least 6 months or more. So basically, until you get to schizophrenia, you are essentially going to be in schizophreniform. Let's move on to talk about schizoaffective disorder. So this is probably the trickiest one to understand. And essentially what this is this is going to be a patient who has some type of mood disturbance. So that mood disturbance could be mania or it could be depression. In addition to that mood disturbance, they are going to have some psychotic symptoms during that period of mood disturbance. Additionally, they're going to have psychotic symptoms outside of the period of their mood disturbance. So essentially, this person has to be manic or depressed and showing symptoms of psychosis, as well as showing psychotic symptoms when that person is not experiencing a fluctuation in mood. And the important thing here is that we need greater than or equal to 2 weeks of the psychotic symptoms in the absence of the mood disturbance. Let's next talk about brief psychotic disorder, which is going to be greater than or equal to one positive symptom for less than 1 month. And this is usually going to be stress-induced. This one's pretty easy to recognize on test day because there's some traumatic event. The person becomes briefly psychotic for less than a month, and then everything resolves. This is going to be the person you diagnose with brief psychotic disorder. Now, moving on to talking about delusional disorder. This is going to be greater than or equal to one delusion for greater than or equal to 1 month in the absence of mood symptoms. So this is essentially a person who is experiencing delusions for longer than a month and they don't have any bipolar or depression. So it's classically going to be delusions as their main positive symptom here. And really, they're not going to have any of the other schizophrenia type symptoms like negative symptoms. And they're also not going to have the mood disturbance that we associate with schizoaffective disorder. Lastly, let's talk about schizotypal personality disorder, which is related to schizophrenia, but these people never go into overt psychosis. They have very strange magical thinking. So they may be into things like Dungeons and Dragons and be part of a satanic cult and have strange beliefs like the fact that they could turn blood into water and drink it. And so these people will come across as very, very strange, but they're not having overt delusions or overt hallucinations or true psychosis or any of the negative symptoms that we would associate with schizophrenia. And so it's important to know that schizotypal personality disorder is related to the schizophrenia spectrum, but it is not going to count towards a diagnosis of schizophrenia or its related counterpart diagnoses. All right, now that we've covered thoroughly the diagnostic criteria of schizophrenia, let's talk a little bit about the pathophysiology of schizophrenia and how this can come up in third order questions on test day. So when it comes to pathophysiology, we're talking all about dopamine here. So we're going to have derangement of dopamine pathways, classically the mesolimbic and mesocortical. Some other findings that we're going to see in schizophrenia are going to include increased serotonergic activity and especially high yield increased ventricle size. So if we look at this head imaging over here to the right, you're going to see that this here, what I'm highlighting right now, is going to be a normal size ventricle within the brain. As opposed to the schizophrenia patient, which is going to be on the right, you notice that this is a much larger ventricle, and this ventricomegaly, the fancy word for large ventricles, is going to be an associated imaging finding of schizophrenia. Another gross finding that you may see on imaging or hear mentioned on test day is going to be hippocampal atrophy. And then in terms of changes at a cellular level, we're going to see decreased branching of dendritic cells within our patients with schizophrenia. And this makes sense to me because I think of schizophrenia as leading to a lot of cognitive decline, and I think of branching dendrites as really active and healthy for the brain. So when we have a decreased branching in these dendrites, it helps me remember that schizophrenia, especially the negative symptoms, are associated with cognitive decline. Talking now about some epidemiology, we're going to see increased rates of schizophrenia in our males. And also, when it presents, we're going to expect our males to get it in their teens to 20s. Whereas our female patients are going to tend to develop schizophrenia a little bit later, usually around their 20s to 30s. Additionally, heavy cannabis use in teenage years has been associated with an increased incidence of schizophrenia, as well as poorer outcomes and more progressive disease. So that's going to be something to be on the lookout for test day, especially with the legalization of marijuana becoming more popular across the country. This may be something that they highlight more on the board exams. Lastly, I want to mention that those living with schizophrenia are at an increased risk for suicide, so it's going to be important to screen these patients for suicide if that comes up on test day in question stems. In terms of our pharmacologic management of schizophrenia, our first line is usually going to be a second generation antipsychotic, and we like these because they have a better side effect profile. So the classic one that I always think of is going to be risperidone, which is a second generation antipsychotic. Now, in terms of side effects, they love to ask about side effects of antipsychotics on the step 1 exam, and I would say the highest yield one for risperidone is going to be galactorrhea. That is a really, really common thing to see in vignettes. Now, let's say you had a patient who trialed a second generation antipsychotic, but it's not controlling their symptoms well enough. We can go ahead and step up to other agents, and so there's a variety of antipsychotics you can choose from, but the one that I want to mention is the gold standard strongest antipsychotic, which is going to be a second generation antipsychotic, and it is called clozapine. That is the gold standard best treatment option for someone who has schizophrenia refractory to other medications. However, it's important to know that these people need to be monitored for agranulocytosis, which is a life-threatening condition in these patients. They can have massive drops in their blood cell counts, and so they need to have CBCs on a frequent basis, which is why we don't like to prescribe clozapine, because it requires heavy monitoring. Some adjuncts to our pharmacologic therapy are going to be electroconvulsive therapy, also known as ECT. This can really help with symptoms of psychosis as well as refractory depression. This is a really great treatment for patients with coinciding depressive symptoms. We can also use cognitive behavioral therapy as well as occupational support, depending on how able this person is to hold a job. We basically want to make them as functional as possible despite the cognitive decline and some of the positive symptoms that may be interfering with life. And then there are patients who develop schizophrenia at a younger age. Family therapy is usually a great adjunct to choose. They love to include this as an option for parents in maybe an ethics question who are wondering how they can better manage their child with schizophrenia who is living at home.